interesting, and I'm not exactly sure what's meant by that, but I did mention common vocabulary that comes from using standardized instruments for justice teams. So I think I would just mention that some of the kind of terms that we would want to become familiar with and use and share an understanding would be things like the DSM formulation for substance use disorders now, which now include mild, moderate, and severe disorders, right? So what does that mean? What does that mean to have a severe substance use disorder versus a mild substance use disorder that would be the result of providing a screening and then an assessment of substance use disorders with a standardized instrument, such as the TCU-5, followed by, let's say, the Addiction Severity Index. So through that process, I think we get a better sense across different types of disciplines in our team about what that means. And similarly, you know, just sharing information about what it means to have a major mental disorder, what some of the diagnostic differences there are, and symptom differences and implications for treatment and supervision and management in a court or prison jail setting for somebody that has bipolar disorder, depression, schizoaffective disorder, for example. And then really about co-occurring disorders, right, which is a huge training area, I think, across our justice teams and your grantee projects, for example. I think you've already done quite a bit of training in that area, hopefully. But we developed vocabulary about what are we talking about when we talk about co-occurring disorders, and the fact that neither one of the disorders is primary, but they're co-equal in terms of importance, and what some of the strategies are for treatment of the disorders. What does integrated treatment mean for the disorders? What does a blended screening and assessment mean? So I think these are some of the kind of vocabulary tools. And then finally, I would just mention, the one thing I did mention earlier about the vocabulary is the risk assessment. So what does it mean for individuals who have high risk? What does that look like in person so that people can begin to characterize what that looks like for your offender population? What implications are there then for strategies to intervene both on the treatment side and programmatically on the supervision side as well to address the differential level of risk for recidivism? And, you know, an understanding, for example, of the dynamic risk factors that underlie the profile of high risk and moderate risk for offender populations that we need to target.
Thank you. Yeah, and something that we end up talking to grantees a lot about too is even the term risk to a behavioral health person could mean something different than to a criminal justice person. So, you know, risk of self-harm, risk of suicidality versus criminogenic risk factors. So just making sure we're speaking the same language becomes a really key area when you're talking about this multidisciplinary team approach as well.
Right,
okay,
good point.
So I think the next question is actually related to cultural competency. So how do you ensure that instruments are responsive to the different cultural needs of your population?
Right. So one thing you want to look for is just when you look at the research on a particular instrument that they've been tested in those populations. And the good news is that they've been tested in offender populations. As we know, it's a pretty diverse group, isn't it, ethnically and racially? So we want to look for evidence that there are not differential outcomes, let's say for a risk assessment instrument or for a substance abuse instrument that's a screen for substance abuse with Latino, Hispanic population versus African-American population and the Caucasian population. You want to have equivalent types of findings for those populations. Ideally, you would have research that looks at a particular screening instrument across those different racial ethnic groups and then examines outcomes using a more comprehensive assessment approach, such as the SCID, right, if you're looking at mental health disorders. So you'd have a mental health screen, you'd apply it to each of these different racial ethnic groups, and then you'd look at how accurate the instrument is in actually determining a bona fide mental disorder as determined by the gold standard, the SCID instrument, right? in looking at the hit rate for that particular mental health screening instrument to look at depression or anxiety disorders or psychotic disorders. Then you'd look and see, well, did the screening instrument perform as well for African Americans as it did for Caucasians and Latino and Hispanic populations in making that crosswalk between the screening instrument and the overall determination of whether or not there was a bona fide disorder. So I think that's one consideration. I think that you can get some information from actually talking with your offenders about whether they understand the information. Sometimes there's language issues, right, for people that don't have, English isn't their first language. And so I think we need to check on that as a basic issue. Sometimes people from different cultural backgrounds have different understandings of different words. And so I think it's important to actually gather some data about what people understood a particular item, what does it mean to them. If you're using a screening instrument or an assessment question that's part of an instrument that you use in a consistent way in your setting, what is the individual meaning for people of different ethnic, racial backgrounds for those items? Is it consistent with your intention and so forth? Just a couple ideas there. I would tell you one thing in terms of instruments, that there isn't as much research as we need to look at different outcomes among racial ethnic groups for the different instruments. And I gave one example of a particular type of research where there was some evidence that there were differences for the SASE screening instrument, which looks at substance abuse, and that there were some major differences there in terms of over-identifying people who are African Americans as having severe disorders when in fact or having a substance use disorder when in fact they didn't. But there isn't as much research as you'd think, as you'd want in that area.
Okay, thank you so much. And another, key topic that we hear people in the field talking about a lot is gender-responsive services. Are there tools for screening and assessment for women that work well for women in the justice system that you would recommend, or what are your thoughts on those more gender-responsive tools?
Well, again, we talked about trauma and post-traumatic stress disorder, and at one time it was thought that you just administered those to women and female offenders, and now we know that that needs to be a universal approach for men and women. I don't think generally there generally aren't instruments that are separate instruments for men and women. There are some exceptions, but most of the instruments have good psychometric properties for both men and women, and that's one of the kind of basic bedrock foundational kinds of outcomes that we look at when we examine research looking at the properties of a particular instrument, whether it's a screening instrument or an assessment instrument. Does it perform as well with women as it does with men? And so any of the instruments that we looked at today would have equally good psychometric properties for men and women. There was one issue with the jail mental health screen at one point that there were some difficulties with women, and that would be an example where I think the individuals who created the instrument went back and looked at whether tweaking and changing the instrument to make it more suitable for both men and women. But in general, all of the instruments that we've talked about are suitable for men and women. There's one example that I shared with you today in which there's a separate instrument for men and women, and that's the correctional mental health screen. And as you remember, that was one of the several mental health screens that I recommended that's non-proprietary, that's public domain, free of charge, and it was actually developed by the National Institute on Justice, that NIJ, and there's a separate form for men and women. So you have the CMHS-M, which is the Correctional Mental Health Screen for men, and you have the Correctional CMHS-W for women. Each of them are a little bit different. So this is interesting. The female version has 8 items. The male item for male offenders has 12 items. And it was developed and psychometrically designed so that the items correspond to those that predict a greater likelihood of a major mental disorder within the gender groups. And so that would be one of the few instruments. I think that there is a separate instrument for men and women.
Okay, great. Thanks so much for the clarification on that point. We're actually going to open it up to the folks who are on, the grantees that are on the line. So we are in the process of unmuting them, and then if folks have questions, they can feel free to ask them as your line is unmuted, or you can also use the chat box as we've been doing. All right, the lines are open. Does anyone have any specific questions for Dr. Peters? Okay, there's one additional question that came in, and it is, are there different tools that you would recommend for court-based programs or mental health courts?
So separate instruments for court-based programs or mental health courts. And I think the answer is probably not. I think most of and I do a lot of work with drug courts, not as much with mental health courts, but have worked with them in the past. And I think that, what's really key for the court-based programs is to provide a universal screening, as we talked about, for both mental health and substance abuse, as well as PTSD and trauma. Also to provide that risk assessment that I mentioned. One of the examples that's used in drug courts quite a bit is a RANT instrument for screening of high and low risk among drug court populations. But again, I think that just as in other programs that provide lengthier treatment services and opportunities to work with people over a period of time, in most cases in drug courts, mental health courts, that's a year or more, right? I think for those types of programs, similar to a residential program, you have an opportunity to provide a lot more intensive, comprehensive assessment process after the initial screen is done. So right up front, I think you're looking for initial screens that would identify major problems related to mental health disorders. You're looking to actually route people into your programs that have a severe mental health, severe substance abuse problem, as well as moderate to high risk, as we mentioned, right? And then on the mental health side, you're looking for individuals that you're not weeding out people with mental health problems, but you are looking for symptoms that may interfere initially with participation in a program. So, for example, you're looking for suicidal behavior, right? You're looking for active psychotic symptoms up front, major depression that may be vegetative, where the person just isn't able to engage in conversation. A lot of these, by the way, you would observe, right, in your personal interviews, screening interviews with an individual coming into a mental health court and a drug court. So for mental health courts, of course, you're really looking at the major mental illness as a point of entry, and you want to screen for people that have major disorders and have a lot of these acute symptoms, whereas in a drug court, the screening and the follow-up assessment would actually try to target these symptoms and look at what's the match between the mental health symptoms that you see in front of you, either particularly from the screening and any follow-up that would occur, and what you can tolerate in your drug court program. So that's an interesting issue because, right, a lot of drug courts have different capacities to deal with different levels of mental health severity in their programs. You might have an urban program in Cincinnati, let's say, that has a really well-developed co-occurring program in a drug court that may have a specialized docket for co-occurring disorders. It's overseen by the judge that also is the drug court judge in that jurisdiction. And in that case, you might have specialized services that provide intensive co-occurring services. And so in that case, you might be able to deal with people that have that aren't stabilized on medication, that may have active psychosis and have paranoia and delusions and hallucinations to start out with, but could be stabilized given the right services within a short amount of time. In a lot of other drug courts, that's not the case, right? So I think in any case, if you have somebody with suicidal behaviors, that's going to be a red flag, and you really are not going to want to take that person into the program until they've been stabilized. But in a lot of other drug courts that don't have specific capabilities of dealing with more severe mental disorders right up front, you would want to target some of those symptoms of acute psychosis, paranoia, delusions, and so forth, that would be contraindicated for drug courts, at least in the first period of time. So one caveat I would share with you is that a lot of drug courts provide a kind of an interim placement. So you could be in a pre-treatment kind of status in a drug court program in which you are asking the person to take part in mental health services that will allow them to stabilize, and so that those symptoms that we just talked about that might be disabling and functionally create enough impairment that would cause problems in drug courts might be reconciled, and that they would actually be stabilized to the point that they could take part in a drug court program. Other drug courts have different kind of tracks for people of different level of severity, so that you'd have initially a track for people that have a major mental disorder that's not well controlled, in which you provide intensive services and medication consultation, crisis management 24 hours a day, 7 days a week. You might have other tracks that provide just access to some of those services for people that need it as over time, but that have mental health disorders that are identifiable up front, in which there isn't kind of impairment related to the immediate symptoms. So, I think that's how we use screening and assessment in a court-based setting. I think that we have the luxury of being able to provide the assessment over time for these individuals, but the screening up front also is very important for these court-based settings.
Thank you so much, Dr. Peters. I'm going to open it up to questions of folks that have called in again. Okay, well, we are not hearing additional questions or seeing additional questions in the chat box. So if anyone has additional questions after the call or after the slides are sent out to the participants, please feel free to email your CSG Justice Center technical assistance provider, and we'll make sure that Dr. Peters receives all of the additional questions and is able to follow up with the technical assistance process as well. So thank you so much, Dr. Peters, for being on the call and talking to our grantees about screening and assessment for co-occurring substance use and mental disorders in the criminal justice system. This is really a cornerstone of the work for all of our grantee programs, so we really appreciate you lending your expertise.
Thanks to everybody out there. Appreciate it, and good luck in your work.
Have a great day. Bye.